The price of drugs in the United States is about to change, with a maximum drop of 90%. Big news! The price of prescription drugs in the United States is going to be reduced. The White House announced a historic agreement with Pfizer, and a new platform called TrumpRx will be launched, promising to significantly reduce the price of commonly used drugs. The official statement is to bypass the complicated links and pull down the drug price, according to the idea of benchmarking the lowest price in developed countries. Some people say that this will be the inflection point of drug prices, while others remind that the detailed rules determine success or failure. Today, we don't argue about emotional changes. We talk about how to lower the medicine point, to whom, how long it can be lowered, and what to do with medical insurance. Before the video starts, please subscribe to us for retweets and likes. One, what is the problem now? To buy prescription drugs in the United States, you often have to take 3 steps: doctor prescription, pharmacy drug collection, insurance claim settlement, and drug benefits, manager rebates, and catalog negotiations in the middle. The price is getting higher and higher, and even if patients have insurance, they often pay out of pocket. Chronic patients feel the most. They take medicine for a lifetime, and the price rises every year. As a result, many people postpone medication, reduce doses, and even buy medicines across borders. This time, the government directly pegged at the price, aiming at the intermediate cost and the international price difference. 2. The core mechanism announced this time is first, most favored nation pricing. Simply understand, looking at the lowest prices of unified drugs in other developed countries, the United States is no longer taking advantage of it. Start with Medicaid in the Public Safety Net project and supply Huirui's drugs at the lowest price. This step has a direct impact on weekly finance, low-income, and vulnerable groups. Second, the direct purchase platform TrumpRx. After the platform is established, patients can place orders directly according to the negotiated cash price, reducing some intermediate links. For people without insurance, insufficient insurance coverage, and high self-payment, the potential benefits are more obvious. The average drop mentioned in the public caliber can reach about 50%, and some varieties can reach more than 80%. However, note that the platform has not officially launched its functions. The way scope governs insurance is still being improved. Third, in exchange for domestic investment and tariff buffers. Pfizer has promised to invest huge sums of money in the United States in the next few years for manufacturing, reshoring, and research and development. In exchange, the government will give phased grace to its tariffs on imported drugs. The overall logic is very clear, with market access and tariffs as bargaining chips in exchange for price cuts and local investment. 3. What practical impact does this have on you and me? 1. People without insurance and high self-payment can get significant discounts through direct purchase prices, which are the most direct beneficiaries of this wave. For example, skin diseases, rheumatoid diseases, and some commonly used chronic disease drugs, once included in the direct purchase list, the savings will be considerable. 2. Patients with chronic diseases who have been taking drugs for a long time. If the variety coverage is in place and the supply is stable, the annual drug cost burden is expected to drop significantly. However, whether each drug is on the first list and how long the discount can last still depends on the follow-up implementation. 3. For those with stable commercial insurance, you have already negotiated a discount through the insurance pharmacy, and the out-of-pocket payment may not be high. The discount price may not be cheaper than your actual out-of-pocket payment, so you need to compare it mainly. However, the downward shift in the reference price will put pressure on the market, and future contract renewal may be more beneficial. 4. Pharmacy PBM intermediate chain discounts and MFN pushing down the price ceiling, and the premium right is moving. The model of PBM and large chain pharmacies is facing a balance, and the rebate space is squeezed, which will promote a more transparent price system, but the industry game will be fierce during the transition period. 4. Chain reaction on the medical insurance system. Medicare is the first to land. Public drug expenditures in various states are expected to decline, and the relief of financial pressure is the most intuitive. However, Medicare and commercial insurance also account for the bulk of drug expenditure in the United States. It is not yet clear when Medicare will fully benchmark MFN, which means that in the short term, the reduction in total drug costs across the country is acceptable. It can lag behind. Once similar pricing logic is extended to Medicare in the future, it will have a deeper impact on the overall asking price limit. At the same time, whether insurance companies should access the price system of TrumpRx also involves a lot of operational details such as catalog management, payment ratio, and pharmaceutical company rebates. Without supporting rules, the patient's price perception may fluctuate. 5. Why does this policy look good? First, he targeted the most painful pain point, and the nominal price was inflated. Whether you have insurance or not, a lower rivet price will have spillover effects on negotiations. Second, he solidified the long controversial card of international price difference, and ended the public opinion disadvantage of Americans paying for world innovation. Third, direct purchase plus local investment in exchange for tariff buffers can not only demonstrate the results of price reduction in the short term, but also increase supply resilience in the medium term. It is a combination right for the chain of production, supply, and price. 6. But why is the outside world still cautious? 1 is coverage. Start with Medicaid and some sufficient lists. Whether it covers large varieties with high expenditures depends on the list. The second is sustainability. The price is negotiated, and how the contract cycle and price adjustment terms are designed determines whether it will rebound in a few years. The third is the time difference between platform landing. TrumpRx has not yet opened the user experience, and the pharmacist review, logistics cold chain, and return and exchange rules must all run through. The fourth is the game between law and market. Most favored nation tariffs, FDA incentives, and any link of various regulations is stuck, which may make the terminal price unable to fight or rebound after fighting. This is both a livelihoods and political strategy. Voter sentiments on drug prices can influence elections. Concurrently, incentives for local manufacturing respond to industrial goals, merging health policy with broader economic narratives. Certain policy motivation and political reality. This is a people's livelihood card too. An election card. Prescription drug prices are one of the most concerned issues for American voters, and visible price cuts can affect voting sentiment more than grand narratives. At the same time, this is also an industrial card, which uses tariff threats and approval incentives to force price concessions, and then uses local investment to respond to the return of manufacturing industry, forming an overall narrative that can be told between pharmaceutical trade and employment. From the perspective of negotiation strategy, this is a typical example of beating first and then wooing, setting a deadline first, then leaving a way back to raise the tariff threat first, and then giving a 3-year buffer. Not only political achievements can be changed, but also industry can be achieved. 8. 3 variables you need to focus on. Variables 1. List and schedule. Are the first batch of included drugs, high usage rate, and high burden varieties? How many steps are there between the platform's announcement and ease of use? The docking method of variable 2. Insurance. Will commercial insurance and employers' self-insurance plans include discounted purchase prices in reimbursement? The self-funded algorithm cannot be opened up, and the real large-scale burden reduction will occur. Variable 3. Industry linkage. In addition to Pfizer, when will the second and third major pharmaceutical companies follow up? If industry price cuts can be formed, the price center can systematically move downward. Finally, who do you think will be the biggest beneficiary of this drug price reform? Medicare people, uninsured people, or Medicare elderly people who may be accessed in the future? Let me know what you think in the comments section. If you want me to continue to track the drug list, platform launch time, and insurance docking progress, remember to comment on this video, like, subscribe, and forward Little Blue Chinese Life, and we will update it as soon as possible.